Studied done in 2017 in Gamache, where they took 40 different brands of melatonin, and they checked to see how many melatonin concepts they use.
Has a voice that projects more than me. I'm Melissa. That there is so much more to sleep medicine and so many more opportunities that are available for you. We would love, any of your table leaders would love to talk to you more about that. Feedback on the session, my filling out the session survey and the those numbers to make this possible for you. And then the post-session survey at the back also gives us feedback about how the session went, what you liked, what you didn't like. And then there's also a QR code to give us your contact information if you want to learn more about sleep medicine, education opportunities, get connected with a mentor. We are very, very happy to talk to you about this unit. I think it's very exciting. So let us know if you have any questions. Ask your here. If you have any questions, open to find any questions, but it's not too bad. That's all I have. Thanks for being with us today.
Every now and then, maybe we'll take a
I guess you guys are really like,
Is it time? Yep. Time to get started? Okay. Hey guys, how you guys doing? My name is Rahul Sharma. I am a sleep medicine physician here. People can come into sleep medicine from every different background. Pediatrics, ENT, pulmonary critical care, psychiatry, neurology, internal medicine, primary care, family medicine, whatever you want to call it. Everything. My background is internal medicine, and when I was an internal medicine resident, I wanted to do literally everything. And so I chose the field that would allow me to do everything, which is pulmonary critical care. Okay. Now, while I was in pulmonary critical care, I really wanted to become a ICU guy only. Then I had kids. That wasn't going to work. And so now I decided to say, you know what I really, really like about critical care and pulmonary is ventilation. And I really started getting into neuromuscular disease and how to help patients with ALS breathe better. Part of that was becoming a master of ventilators and devices, home ventilators, non-invasive ventilation, BiPAPs, BPAPs, all of these different types of devices. And my mentor said, the people that really control those are sleep medicine doctors. And that is my path into sleep medicine. So you can go all which way and still end up at sleep medicine somehow, 8 years later. And I'm so, so happy. Sleep medicine is a fantastic field. There are lots and lots of jobs available because a lot of people in sleep medicine are older and retired. So there's going to be lots and lots of jobs available. Sleep medicine is a purely outpatient field. When you're on call, like you might get calls from the sleep lab saying, hey, I've got this patient who's having a seizure. What do you do? The answer is usually 911. You see, I mean, you're not going to go in and do anything about it. Okay, so that's really, really cool. It pays similar to most other internal medicine outpatient only fields. So you can expect when you leave, you're probably going to get 250,000. And then depending on if you go into a rural area, you might make a lot more. These things are important to know. And I would say that overall, the quality of life, I mean, is probably better than most internal medicine fields. Very, 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 very happy. And especially working at the VA, quality of life is even better. Okay? So, exactly. Now, you guys want to learn about sleep apnea. So before we learn about sleep apnea, we got to break down what sleep is and what apnea is. So who can tell me what is sleep? Isn't that like the hardest question ever? I mean, what in the world? If I just close my eyes like this, how can you tell if I'm sleeping?
Decrease response.
Decreased responsiveness. So basically your sensory inputs, touch, sense, feel, smell, whatever, all that goes down and I might not be able to tell. Okay. How are you going to know for sure? I could be pretending.
Your brain changing signals like data waves.
Right here.
Spindle complex.
Spindle complex, whatever all these weird words are, squiggly lines. Okay. So that's exactly right. There was this guy, Hans Berger. Who's heard of Hans Berger?
Wow.
Oh, you guys are so good. See, you guys are so smart already. Hans Berger was this German guy. Like the 1890s, he was riding on horseback, cavalry, to go join the German army. Back then, they just had horses. And while he was riding, he fell down and he hit his head. He never made it to join the army. And when he was about to join, apparently that whole platoon got blown up and he thought, this is amazing. And his sister said, you know what? I had a dream that you were going to fall off horseback. And he said, oh my God, there must be some sort of telepathic connection. And he believed that there could be some electronic brainwaves going between him and his sister. And so he devoted his life to figuring this out. And you know what he discovered? The EEG. Hans Berger invented the EEG. And that is what led to the discovery of that sleep is different from wake. We put a couple of electrodes on your scalp right now, and I would pick up these brain waves, and they would look like this. And when I say I'm talking about hertz. Hertz means frequency. How fast am I detecting brain waves from you? Right now, all of your brains are taking in auditory inputs, visual inputs, tactile inputs. Your brain is processing so fast every which way. You're processing about 15 hertz, 20 hertz per second. It's wild. When you go to sleep, all of that starts to phase out. And when you fall to about 8 hertz, that's what we call sleep. And throughout the night, you go from light sleep, which is 8 hertz. 8 hertz is what you all have done in school. You might even do it while I'm talking, where you kind of just go like this. And somebody says, dude, you fell asleep. I didn't. Because when you're still at 8 hertz, you're still taking in some information. You might still hear what the teacher is saying. But eventually, I don't know how many have kids, but eventually you go into what's called a deep sleep, where it's just like half a hertz. You're barely picking up anything. And that's the kid that falls asleep in the car, and a parent can pick him up. The kid never wakes up. They flop him in the crib, and the kid's like, didn't know what happened. And that's called deep sleep. So your brain goes from wake to light sleep, deep sleep, and there's one other type of sleep. What do we call that? REM sleep. REM sleep really marks the beginning of sleep medicine. REM sleep was discovered in 1954 by a guy by the name of William Dement. He's from right here. Wenatchee, anybody know Wenatchee, Washington? Born there, went to high school, I think, in Walla Walla, still has family all around here. And he was, I think he was born in like 1913 or something like that. And he loved dreams, and he wanted to become like Freud, right? And that's all he cared about. He just wanted to learn what is going on with dreams. And he went to University of Chicago, where he did medical school there. And then he met this guy, Nathaniel Kleitman, who was basically the only guy that thought sleep could be its own field. Back then, everybody just thought sleep, there's nothing happening in sleep. You're just out of it. It's a worthless thing. People used to say, you'll sleep when you're dead. I've got so many more important things to do. Da Vinci, apparently famous, and would sleep like 20 minutes, multiple times a day. Never would sleep the entire night. People didn't value sleep. Even though if you think about it, evolutionarily, how is sleep even here? When every animal is asleep, they're open to prey. They cannot watch their surroundings. They cannot take care of their young. And yet sleep has survived billions of years of evolution, and every single animal sleeps. Is that wild? Shouldn't we care about that? And so that's what Dement thought. So Dement and Kleitman at University of Chicago started studying people with Hansberger's electrodes, and they started seeing that brainwaves differ, and that there is one part of the night where it was actually discovered in a nursery of newborns, where somebody was observing newborn sleep, and they started noticing this: eyes darting back and forth. And then they started studying that, and they started putting EMG electrodes on bodies, and they realized that every single muscle in the body, except for the diaphragm, and you guys are better than this than me. What makes you go lateral? Whatever.
Our neuropreluminal memory.
Some sort of ophthalmic muscle. That's the only thing that's working in REM sleep. Okay. And so they discovered that, and they said, all right, now I'm going to put this on a bunch of adults. So they put electrodes on adults, and they put these EOG, electrooculograms, kind of little electrodes that sit here and here. And they said, oh, your eyes are darting back and forth. As soon as they got that, they woke him up. Wake up. And they said, hey, what were you feeling anything there? Oh yeah, I was seeing a dog over here and a cattle over here and blah blah, and I was farming and da da da. They said, oh my God, this is dream sleep. And now we started doing, and back then they couldn't afford to do EEGs all night. Finally, somebody was able to pay for that. Finally, somebody was able to pay for that. And they started noticing that we go through cycles of light sleep, deep sleep, REM sleep. We wake up, light sleep, deep sleep, REM sleep. We wake up, light sleep, deep sleep, REM sleep. Everybody goes through about 3 or 5 cycles a night. So they called that rapid eye movement sleep. They didn't have a name for the other ones. They just called it light and deep. So logically, what was the name for that? Non-REM. Pretty simple. And then they just said, oh, okay. And we think that there are spindles happening here. We're going to call that 2. We're going to call the lightest sleep 1, where you don't have any spindles, 2, where you have some spindles. And then when you're super, super deep, we're going to call that 3. And then you have REM, and that's it. So sleep is really, for us as sleep medicine doctors, it's really an EEG state. And there are lots and lots of physiological things happening in sleep. You have growth hormone release, you have norepinephrine and epinephrine release. During REM sleep, then everything calms down. During deep sleep, growth hormone is released during deep sleep. And then all of a sudden, cortisol all calms down then. And then it starts to ramp up when you wake up in the morning. Epinephrine or epinephrine start to ramp up. We think that memories are formed at night. We think that the reason kids have so many spindles on an EEG look like this. And then back to normal. Back to normal. So it's really, really fast and doesn't make any sense. It just comes out of nowhere. And kids have a ton of them. And we think spindles are important for memory. You have them too. Everybody has them. We think they're important for memory formation. And then there's this new thing that's being discovered that happens in deep sleep, which is there's something called the glymphatic system. Has anybody ever heard of that?
Yes,
Right?
heard of that.
It's actually a lot in pop culture and the news. If anybody follows like podcasts like Andrew Huberman, and if you're on Twitter,
I have like a friend who like grad school who did lymphatic research.
yes. So the glymphatic system is all the new hotness. And what we're discovering is that it seems to get rid of toxins and waste, one of them being tau. Oh, mind blown. Neurology? Mind blown. Now we think that if you don't get enough sleep and you don't get enough deep sleep, might lead to Alzheimer's, might lead to dementia, because you don't get enough of that lymphatic system circulating and getting rid of all these bad things, these bad toxins. So I tell you that to tell you That sleep is so young. We're still discovering what is the purpose of sleep. Okay, I cannot actually tell you what would happen if you didn't have any deep sleep, or if you didn't have any REM sleep. There is one thing that we have learned. Who's heard of delirium tremens? Right? Anybody ever seen a patient in DTs? You have. What happened to that patient? What was he doing?
Drinking a lot beforehand. And I had a lot of like hallucinations and very like
Agitated,
agitated.
going crazy.
Yeah.
Yeah, yeah. And you know, when you're in the ICU, you'll probably see a lot of people going through DTs because they have to be really, really monitored. Heart rate is going through the roof. They're seeing all these different things. They're acting out. They're kicking. They're thrashing. Everything is wild. Well, DTs is REM during wake. You see, alcohol is a REM suppressant. When you drink a ton of alcohol, you might go to sleep a little bit faster. Most of the time, you probably wake up a little bit earlier. You wake up earlier than you want to. You wake up multiple times throughout the night. It suppresses REM sleep. And you drink it over time. You keep drinking and drinking and drinking. Your REM is all the way gone. Now I pull it away. And guess what? The REM comes back in a hurry and it doesn't care whether you're asleep or awake. And now you're seeing dreams and visions. And what would everybody do? Everybody would try to fight that tiger. Everybody would try to fight that person that's chasing them. And in REM sleep, your heart rate is all the way up. In REM sleep, REM sleep. REM sleep is literally like you are awake. Your EEG kind of looks like it. You really can't tell the difference. The only thing that happens is everything is paralyzed, except for the patient in DTs. They're all crazy because they're kind of awake. REM is trying to come in, wake is trying to come in, and they're all sorts of messed up. Okay, so that's sleep. Sleep is a very, very important process. It's stayed in our evolutionary history for a reason, and we're still discovering the main purposes of it. There are lots and lots of studies that show that increased sleep, where you can get 7 to 8 hours sleep, will increase your performance. We did a study, not we, but somebody did a study on University of Washington basketball players. Have them shoot jumpers from one spot when during the normal sleep, then force them to get an hour extra of sleep, repeat that same test a week later, their percentage improves. This has been replicated over and over and over in athletes. It's been replicated in like vigilance testing. So that means if I see a dot here, I blink. If I see a dot, or I click, dot, click, dot, click, dot, click, dot, click, dot, click. And just 1 hour less of sleep, that response time decreases. So sleep is very, very important.
Yeah. I'm just thinking back to my 28-hour call shift when I'm driving home and I'm like, oh, this should be good. This should be
Right.
good. Uh-oh.
Right. Duty hours. Duty hours. A lot of it driven by the fact that vigilance decreases. Brain doesn't process as well if you're awake. And it all started with that that case in New York. When was that?
Libby Zion.
Libby Zion. What's that,
Same with
1990s? Libby Zion was given, what was it?
Oh, I don't remember the details.
She was given a drug while she was on an SSRI, and it caused her to go into serotonin syndrome. And the ER physician had been working like 36 hours, and their attending was away, and they didn't check the fact that she was on that SSRI. Actually, it was an SSRI. It was an MAOI, monoamine oxidase inhibitor. And I forget exactly what the name was, but she was given a drug that we hardly ever give now, and I also forgot the name of that. But anyways, those combined, and that's when Libby Zion's parents went on a attack on the hospital system, on the political system, and that's how you guys ended up with better work hours than those people. And now that almost
8 hours better.
now that I'm a sleep position, I look back on my college years and even med school years of pulling all-nighters. I feel like that was a disaster. It was bad.
1984, it was Demerol.
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 Nice. Yeah, excellent. Demerol.
Wow.
Nobody gives, or I don't give Demerol anymore. But anyways, so sleep. Questions about sleep? Everybody understands sleep now?
Experts now.
Experts. So that's sleep. Now hit me with apnea. Apnea is a lot easier. What is apnea? Stop breathing. Excellent. So we had to define what an apnea was, because you can stop breathing for a second, 2 seconds, 3 seconds. So what did they choose? Nice. 10 seconds. And that was Dr. William Dement, our Washingtonian. He came up with everything that I'm going to tell you today. He passed away last year at the age of 99. I saw him at a sleep conference 2 years ago, or 4 years ago, rather. So William Dement, he's the father of sleep medicine. And he was the one discovering all this, discovering all what the apneas were. And he discovered there was something called a hypopnea. What's a hypopnea, if you have to guess? So one is stop breathing, one might be excellent, not enough breathing, or shallow breathing. And see, the way we measure whether you're breathing or not is via a pressure transducer. So I'm going to put a nasal cannula in here, in your nose. And this nasal cannula is going to detect whether air is coming, air is going. And it's going to go through a transformer and make it into a digital signal that looks like this. Okay? Now, when this wave, so this is breathing in, breathing out, breathing in, breathing out, and like this, that's apnea at 10 seconds. And then if I breathe in, breathe out, and then just a slow amplitude, short amplitude, down, deep, 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 deep. Hypopnea, also 10 seconds. All right? And we have specific definitions where we say 90% decrease in amplitude is an apnea, so you don't have to be all the way off, and 30% is hypopnea. You don't need to know that at all. I just tell you because I think it's fun. Okay. So, in the 70s, people started to note that really, really obese patients were kind of really tired during the day. They were kind of sleepy during the day. And there's a Shakespearean term for those patients. Anybody? You've heard it, probably. What is it? What? Somnolent? Yeah, somnolence, yeah, sleepy. But the term that was given was Pickwickian syndrome. Who's heard of that? Yeah, yeah. And it was from this 1800s book that, not Shakespeare, sorry, Dickens, the Pickwick Chronicles. And there was a character in there, not Fat Joe, but not the rapper, like Fat Tom or Fat something like that. Anyways, he was called Fat something, and he was like always sleepy, and people thought, oh, this is all just related to carbon dioxide. We discovered carbon dioxide way long ago, and they just said, oh, these patients, they all have high carbon dioxide, that's it. That's what's causing their sleepiness. And then it wasn't until the 70s that this William Dement guy and this other guy with a really, really long French name, just call him CG. He also passed away last year from Stanford. And anyways, they said, should we study these people at night and just make sure that they're not sleepy because they're not getting enough sleep at night? And that's what they did. They put this little transducer in here. They put an esophageal probe to measure their breathing at night. And they noted that these people, they stopped breathing at 30, 40 times an hour. And so they took a patient like that and they drilled a hole in their neck. What's that called? Tracheostomy. That's right. And guess what?
They were better.
They were better. Oh my God. They were not sleepy anymore. So did that have to do with their sleep apnea? That's what they called it. Because at that time they hadn't discovered hypopnea. That came in the 80s. sleep apnea or was it carbon dioxide levels? It didn't matter because everything just got better because we drilled a hole in their neck. Is that awesome? Well, I think it's pretty cool. That's right. That's right. And then there was this Australian by the name of Colin Sullivan. He was a physiologist. And he said, guys, I really think doing these trachs on everybody is just not the way to go. I think sleep apnea is pretty common, and we got to find something else better for this. So he created a dog model. He created a dog with sleep apnea. And then he took a vacuum cleaner. Okay. He took this vacuum cleaner and he flipped the motor, made it go reverse. Can you believe that? And he just stuck it on the dog. And that night, the dog didn't have sleep apnea. What is that? Is that wild? Then he took this and he published this. He published a vacuum cleaner going in reverse and said, I'm calling this the Sullivan machine. And he did.
Of course he did.
And then he took this truck driver and he put his vacuum cleaner on this truck driver that he had diagnosed with sleep apnea. And the truck driver woke up and said that was the best sleep I've ever had. And now you've got your CPAP. 1980. And his device eventually led to the creation of this Philips Respironics company that creates CPAP, and then eventually a competing company invented called ResMed, and those are the major two companies that create CPAPs today. And then eventually somebody said, hey, let's create something called a bi-level, right? You guys have heard bi-level. You guys may be calling it BiPAP, but bi-level is the actual name. BiPAP is the trade name by Respironics. The actual machine is called a bi-level, and that came in the 2000s. And then after that, we were just off to the races. Now we got a million machines, all these different modes, all this stuff once technology developed. Cool? Now you know everything about sleep apnea. Now should we do these major learning goals?
Yeah.
All right. Questions about any of that? I thought you were going to ask me some dumb questions. Okay, go ahead.
Did sleep medicine come before like the ventilator was invented?
That's a great question. No, the ventilator was already there. You know, they had iron lungs first, and I don't know if you know how iron lung works, but it's this iron piece of equipment. I put you in it, and I change the pressure inside a lung by pumping things. So the way you would ventilate a patient in like the 1930s with these iron lungs was you would have to have somebody there 24/7. Otherwise, the patient wouldn't breathe. So you have to have a nurse or somebody doing this just all day and just doing shifts of this. Because we had all these people.
Automated, that is.
Oh, no, not in 30s. You better have somebody there. So that all was going on, and then eventually I think somebody came up with the ventilator, but I'm not fully sure actually. Good question. Now I gotta look that up. No. Okay. Describe common scenarios for home versus lab-based sleep testing. So lab-based sleep testing was what William Dement was doing, where he's just spending the night with the patient, watching them sleep. Eventually we came up with a video so that a person wouldn't have to be in the room because that's creepy. So we came up with a video camera. And then he said, well, I've already got electrodes here. I have to measure their breathing with this. Do I really need the esophageal probe? We eventually popped that out. We realized we didn't need that. So what did we replace that with? What was that? Yeah, something on your chest, because the esophageal probe was measuring diaphragm exertion. And so we're going to wrap a belt around your chest and a belt around your belly. And now we'll be able to tell whether you have chest rise and belly rise. Okay, so we've got brain going. We had eyes going. We need that for REM sleep. We've got nose going because we need that for the pressure transducer wave. But sometimes you have people that are mouth breathers. So how would you fix that?
Tape it shut. Oh. Or
Hey.
You could put a different sensor.
You could put a different sensor, or you could tape it shut. I have patients come in with all these tape marks and they're like, yo, I'm just trying to breathe through my nose. And there is actually a study uh, done recently that showed that taping your mouth with this 3M surgical tape actually did improve sleep apnea.
That's the thing on TikTok people are doing.
It's a thing on TikTok.
Just for
See?
sleep.
I knew somebody was doing that. I know you're doing it. Okay, so, but you're right. We need something to measure what's happening from your mouth too. You can't just have a transducer in here. You have to have something here. And so we created this thing called a thermistor. A thermistor is a resistor that changes conductance based on hot or heat. And so when you breathe out, hot air comes out and it changes conductance and it detects it and turns it into a digital signal. So you're wearing this nasal transducer, a thermistor that dangles in front of your face. And then because we have to make sure that REM sleep, everything is paralyzed, we put on chin electrodes. Okay, because the chin has all this tone all throughout the night except in REM sleep. So think about how much crap you've got on your face as you're going for the sleep study. So when you are ordering your patients to go to sleep study, they're wearing glue and all this stuff on their scalp, glue and stuff here, nasal transducer, thermistor, chin leads, then belt, okay? And then we have to make sure that the legs, you guys have heard of periodic limb movements and restless legs. So we put some EMGs on your legs. Then on top of all of that, we got to measure heart rate. And so you have one lead on your heart. Lead 2 of the EKG. It's not very good, but it's fine. And that, my friends, is a full PSG. You're getting all these signals, 18 signals in total, that I look at every 30 seconds throughout their study. And I look to see what's happening in their brain, look to see what's happening with their breathing, their heart, if they're having a seizure, all these different cool things that you can do. So that is an in-lab sleep study, and a technician is there watching, making sure all the signals are looking good. And you know, you guys already know how to score an apnea and a hypopnea. So, but you can imagine that takes money, a lot of resources, because you can't reuse all this stuff, so you gotta like throw it away, get a new one for a new patient. Plus, how much space are you gonna have for a sleep lab? Like our sleep lab isn't even this room big. Our sleep lab is 6 bedrooms, and we only use 4 because the other 2 are used for storage or something. And we don't have enough technicians. So most sleep labs are kind of being phased out, and healthcare insurance companies said, I don't want to pay for this. So we got to come up with something better. If really all we're diagnosing from these patients is sleep apnea, do you really need all this stuff here? Do you really need here? Right? Sleep apnea is so common. Sleep apnea occurs in 30% of your patients. So you got to find something better. And so they came up with these home sleep studies. So home sleep studies are, there's 2 different types. One is where we just give you a nasal transducer and a belt and a pulse oximeter. That makes sense, right? I just want to capture your breathing. That's it. So your patient could do that. And then another option is something called a watch pat. Who's heard of that? Watch pad is cool. A watch pad is like an Apple Watch. Okay, you put it on here and you put a pulse oximeter on, and that's it. How could that possibly capture sleep apnea?
Ocean or something?
Motion. It does have an actigraph on it, which measures motion. But how could it detect whether you stop breathing? You are correct. We're using the pulse oximeter here. And then this watch is measuring something called pulse arterial tone. Because guess what? Every single time you stop breathing or you have shallow breathing, your brain feels like it's being choked out. And what happens? You go into a fight or flight response. And what do you release?
There are things that work.
Epinephrine, norepinephrine, pumps up your heart rate. It grabs onto your alpha-1 receptors and it decreases your arterial tone. And eventually that leads to a lot of bad complications, right? High blood pressure, heart disease, and all these different things we think happen with sleep apnea. But the watch pat captures your arterial tone going down and says that is an apnea event. I link it with my pulse oximeter, done.
Is there a threshold for like the changes in your arterial tone that it captures and says like this, you have to have X% change in your arterial tone to like qualify an outbreak episode?
You are correct. Absolutely. When you watch this, it actually looks like a little triangle. So normal, 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 and then oh my God, I'm having an apnea event. I'm having it's too tight, it's too tight. Right there, apnea, right here. And then when you wake up and you go, and then you breathe normally, and your arterial tone pops back, and you just repeat this cycle over and over and over again. And you just get these bursts of norepinephrine, epinephrine, down, up, down, up, down. That's really, really bad. We think. Okay?
We can order this, right?
That's right. Yeah. Now, in some rural places, my parents live in Indiana. I just asked my dad to get a sleep study, and his primary care doctor ordered it. So, not in every institution. At the VA and at University of Washington, sleep medicine doctors order it. But you guys might practice somewhere where you have to decide whether somebody needs an in-lab sleep study or a home sleep study.
Is it more expensive with insurance companies than the HSAT?
Yeah, so they're both HSATs, which is home sleep apnea testing. So WatchPat, and the other type is something we call a Knox T3. So they're not more expensive, they're basically the same. For an insurance company, it doesn't really matter. It's whatever you have available. Oh my gosh, we have pictures. What are we talking about, guys? Look at all these pictures.
Wear a CPAP machine like some of the time and they sleep in it.
Yeah. Okay. So, if you have a patient, and this is going to be pretty common for you guys, right? Patient comes to you and says, "Hey, listen, I feel like I'm not sleeping really, really well. My wife is complaining, or my husband or partner is complaining of snoring, that I'm really bothering them." And you look at this patient and you have to decide, I think this guy might have sleep apnea. You got to decide what kind of test you're going to order, right? So how are you going to decide whether you want to do this entire in-lab sleep study that's going to cost $3,000 to the insurance company, or you're going to do a home sleep apnea test? Depending on the type of insurance they have, you might not have a choice. Now, a lot of insurance companies are basically saying, unless you have a very compelling reason to do an in-lab study, everybody needs a home sleep study. Okay, so when I was practicing at University of Washington, everybody got a home sleep study. Unless we had a very compelling reason, and the compelling reasons are the coolest parts of sleep medicine, which is I was strangling my wife at night. That happened. Okay, or I woke up and I was just like punching my dresser because I thought I was boxing them. You probably want to study that in a sleep lab and monitor them. Yes, exactly. Right? So unless you have a compelling, otherwise you're going to be forced to do some sort of a home sleep test. The people that are most ready, most ideal for a home sleep test are obesity, BMI greater than 30, somebody that has snoring, choking, gasping, and witnessed apneas. Witnessed apneas is the partner saying, I keep seeing this guy stop breathing. Okay. And or they have high blood pressure or some other sleep apnea related disease, which
Blood pressure
high blood pressure.
is technically considered a reason for an interesting.
No, not in lab.
Just
Home sleep, home sleep.
sleep.
Yeah, home sleep test. Because we have a pretty good correlation that to treat high blood pressure, if you're going on to your third or fourth medication, you should definitely make sure that they don't have untreated sleep apnea. Treating sleep apnea is about the equivalent of adding a third or fourth blood pressure medication. There is. But when I tell you, you're not gonna like it. No, oh, dude, if it was 5, we'd be really happy. It's 2. I'm sorry to say, but
It's 2.
it is 2. I know. I hear you. I hear you. But listen, you know what? I'm not even gonna justify it. It's 2. Whatever. Take it. Apparently, this is what in the study, it was significant, right? P less than 0.05, but they said it was the equivalent of adding. So you've already got somebody on 3 medications or 2 medications, you add another one. It was the equivalent of that. So maybe these other medications are only doing 2 to 5. I don't know. So, yeah. There's a lot of. Okay, so tell me again, who's the right patient for a home sleep apnea test?
Wait, with witness out and.
Exactly. You have to have obesity to be ideal, and then either storing, choking, gas, and witness apneas, or a sleep apnea related disease like high blood pressure. By the way, technically, there's a million sleep apnea related diseases that qualify, so it doesn't matter. Like diabetes, anxiety.
I would say, yeah. Do you care if we mention people's sleep circumference?
Do I care? No,
I never
absolutely
do
not.
it. I never do it.
No, no, I do not care. I also don't care whether they have a Malin Potty 1 or a Malin Potty 8. Is that even a thing? Okay, no, that does not matter. There is no correlation that we have found between the malampottiness of somebody and their sleep apnea. There is a different type of score that you guys do not do. There is a Friedman score. It doesn't matter. Don't worry about it. Go with symptoms. Everything sleep apnea, you need to be thinking symptoms. And when you treat sleep apnea, you need to be thinking symptoms. Don't worry about the number. Don't worry about what the CPAP says. Do you feel better? Are you having a better night's sleep? Do you wake up feeling more refreshed? Are you having less sleepiness during the day? That's what I care about. Because so far, there isn't any randomized control trial that says there are any cardiovascular improvements in patients who use a CPAP for their sleep. 0. There was a giant paper that shocked the sleep community just last year that came out from the AHRQ. I don't know if anybody's ever heard of it, but it's a Medicare-sponsored a research project. And they said, can you show that sleep apnea or treatment with CPAP improves any patient-centered long-term outcomes? The answer was no. They said it didn't improve high blood pressure, it didn't improve cardiovascular outcome, it didn't improve mortality, it didn't improve car accidents, it didn't improve anything. It 100% doesn't help with weight loss.
People are feeling better.
I'm gonna blow your mind right now. You want me to blow your mind? The study showed the opposite. Weight gain. Why?
It has to do with like rebound of cortisol.
That's not bad. But they actually said it was because at night, it was kind of like you were exercising because you had all this elevation in norepinephrine and epinephrine. And so that's why we think because you lose that, and now you're not exercising as much, and these patients didn't lead to any more exercise. That's the hypothesis of why there might have been weight gain on that study.
What time frame? It's like a couple years, like.
But it was not a randomized control trial.
No, it's like 6 months.
With intent injury.
But if you're talking about the long-term studies, you got long-term studies, 5 years, showing no improvement in cardiovascular outcomes. So this is why I say it's all about symptoms. Okay, because every single person you put into these sleep apnea studies has to be non-sleepy. Because you cannot randomize a person who's sleepy during the day to non-treatment. Right? That's too dangerous. We
Mask on them and like not have any positive pressure on it.
sham CPAP.
Yeah, like there's things.
There are things, but how are you going to put a sleepy patient on a sham CPAP? What if that patient then drives to work the next day and gets in a car accident? Are you in trouble? See that these are the little caveats. These are the caveats. You don't need to find every single person with sleep apnea. You have to find the symptomatic sleep apnea patient and treat him or her or them.
And so you're saying CPAP is only symptomatic treatment, or there's like no real benefit to it?
In the sleepy patient, we think that there are lots and lots of benefits, but in the non-sleepy patient, so far there's no trial to show that there are benefits. I hate to poo-poo on CPAP, but that is the truth.
My husband that snores, who doesn't have daytime sleepiness or whatever, would not benefit from CPAP in any long-term.
So far, I cannot tell you that there is a trial on that. Right. It's like these studies are not the end all be all, but so far I can tell you that we haven't really found anything. Now he will improve his snoring. I mean, snoring is going to absolutely get fixed with CPAP. Right? Why? Pressure. Because think about your airway like a straw. All right. I pinch that straw in the middle. Why does snoring happen?
The opposite of laminar flow through a hole. Turbulent flow through.
These tissues are all collapsing here. I suck in even harder, and I'm going to vibrate those tissues, so I can make the snoring sound now. So if you had a collapsing straw, how would you then open up that straw? You would go, and that's what a CPAP does all night. So you will not snore. There are lots and lots of other treatments. Apparently, we're supposed to discuss that at the end.
So if there's no benefit other than symptoms yeah, you know, whatever. A patient probably would see benefit more from weight loss than they would from being on CPAP.
Oh,
They could from
I love that.
symptoms.
I love that.
For example.
I love that. I love it.
Or like telling my patient my old best be on CPAP.
I love it. Listen, CPAP is like I go to McDonald's, I order 2 Big Macs, I order a large thing of fries and an apple pie, but then I have a Diet Coke. CPAP is a Diet Coke. You see, you've got to cut out the smoking, the obesity, all the other good heart health things you're doing. To smash your patient in the head with a CPAP is probably not the best use of your very limited time with that patient.
Good. That makes me feel better that I'm not doing it.
Additionally, there is a correlation. There is a correlation. And by the way, I'm not saying don't think about sleep.
I know.
I'm just saying don't smash them in the head with CPAP. There is a correlation between weight loss and reduction in AHI. So you have a patient that comes in, they don't want to use CPAP. You can just hammer them with lifestyle changes. Sir, did you know that tobacco smoke and alcohol, they reduce the muscle tone in your throat, and therefore that's going to increase sleep apnea? Did you know that when you lose weight, every 10 pounds you lose has a 3% reduction in your AHI? Because when you lose weight, you also lose the size of the adipose tissue that's around your neck. Oh my God, that's amazing. Did you know that when you have less of a belly, it doesn't push up as much on your diaphragm, and so you have more lung volume? When you have more lung volume, you have more tracheal tug. Your trachea is more taut, less likely to collapse. Therefore, the upper airway is less likely to collapse. All of these things happen with weight loss. In addition, did you know that independent of weight loss, exercise improves tracheal or upper airway tone? Why is that? Yes, but we think it actually improves the muscular tone because we're going.
So then only like higher end. I'm just like going for a casual stroll.
You are correct.
Has to be at least moderate.
You are correct. You are correct. Yes. In fact, there is another published way of treating CPAP with oral exercises. Patients that play the didgeridoo, which is a Australian instrument. Apparently, when you do that, you also strengthen your upper airway musculature. Yes, and that has been shown to improve sleep. Say it again.
Storage app? I've never learned
I have heard of that app. I haven't played around with that, but there are published data on oral exercise.
So right now, I'm in the perioperative medicine clinic and we're doing like clearance for surgery. And part of our template is to always do a stopping on our patients and our patients who have sleep apnea or who come in and we're like, we know you have sleep apnea and none of them use their CPAP or the bi-level. And we're like, you have to do this before surgery. Or like I saw a patient who had been delayed more than a year because they weren't using their CPAP and they were hoping that compliance would improve their pulmonary outcomes and reduce their risk in the perioperative or postoperative period. And you're telling me that that's not true?
No, I'm not telling you that.
Okay. Okay.
No, I'm not telling you that at all because
But it
see what
doesn't
happened.
have an effect on their cardiovascular outcome.
Yeah, but we're talking long term. But my patient that comes out of the PACU with some opioid still in their system, who
Sure.
has reduced ventilatory control. Yeah, I'm a little bit concerned that they're going to become too hypoxemic. So I definitely want them on some sort of PAC.
Before they're like
No, post.
totally.
Yeah,
It's like
post.
a recommendation, but it's not like using their CPAP for like
A week
2
before.
weeks before
Yeah.
it's gonna make any difference. But like in the recommendations, they're like, hey, consider using bi-level or like some kind of non-invasive pressure for these people, like
Post-op.
that are getting a
Post-op.
post-op like recommendations that we're
I think
making.
it's probably
but-
behavioral, like they want the person to do it beforehand so they can feel reassured that when they go home, they're actually gonna do it.
See, this brings us to this next major learning goal, which is understand the AHI and how it is used. You see, we think that there are certain categories of sleep apnea that you guys might have heard of it: mild, moderate, and severe. So 4 people got in a room in the 1999, and it's called the Chicago criteria. And they said, I think we have to have something that separates these patients into mild, moderate, and severe. And so they just chose 5 to 15, 15 to 30 was moderate, and greater than 30 was severe. They just chose it. You see, they didn't link it to how bad was your hypoxemia? How many times an hour were your oxygen levels dropping? How symptomatic are you? How miserable is your life? What's your quality of life like? They just said, let's just give the patient a criteria based on number. Hey,
Elizabeth is sending me around to say that people have a break when you have a
we
moment.
haven't even started.
I know.
No,
but
I'm
that's
just kidding. All right, take a break.
That's fine. That's no.
So, mild water, it doesn't correlate with anything in terms of symptoms. Why? Okay.
You are asking mind-blowing questions. You see what I'm saying? This is the current controversy in sleep medicine. Is what's the deal with this AHI? How much does it even really matter? Should we even be calling patients mild, moderate, and severe based on AHI? There are so many more important things to sleep apnea than just the freaking AHI. We don't treat numbers. This is happening right now.
So it's just around severe sleep apnea and mild sleep apnea, they wouldn't change your recommendation to treat CPAP if they're not symptomatic. But if they are symptomatic, then it doesn't matter what category.
Going to sleep medicine. I'm telling you, you're nailing things here today. That's exactly right. If you are symptomatic, I do not care if it's your AHI is, 5 or 50. I want to treat you. It turns out, I just had a patient with an AHI of 120. All right. That means on a sleep study, I saw him stop breathing twice every minute. Okay. And I talked to him. I was like, hey, how's your life? Oh, it's not bad. Sometimes I can't really sleep more than 7 hours a night. This guy is sleeping 7 hours a night. He stops breathing 120 times an hour. Okay. I was like, so how do you feel during the day? I feel a little sluggish in the morning, but after coffee, I'm good to go. Oh. Yeah. Right now, my other patient, AHI of 7, is the most sleepy patient of all time. You explain that to me. You can't. And that's why we're really not sure if this mild, moderate, severe criteria is correct just based on that one number. There are so many more other things that you get, like how long are you below 90% oxygen saturation? That could be a problem. That could be a problem for your brain. That could be a problem for your heart. But this number just by itself,
I don't know anymore.
I have reservations about that, and everybody does. The take home should be symptoms, 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 symptoms.
You can make a committee?
Oh, there's lots of committees already.
Sorry.
They're all over it. They are all over it. ASM, ATS, they're constantly talking about, guys, we need to do something about the HI. There are articles that come out, you can look at them in our sleep medicine journal called JCSM, a Journal of Clinical Sleep Medicine, called sleep apnea more than meets the AHI. AHI, do we even need it? Just, it's all out there.
Lots of talk.
This is happening now.
No action.
No action.
Well,
I'm not.
Sorry.
No.
It's great.
Things move slow now.
No, they have control.
It's a big bad connotation of untreated schizophrenia. It's a right side of the heart failure.
Oh,
Nutrition that like predicts somebody's risk that will push you to treat someone, even if they're not consistent.
yeah, that's excellent.
It's a big concern.
That is excellent. Yeah. Yeah, so pulmonary hypertension divided into 5 different categories. And I think it's, what is it, group 3. We always think about sleep apnea, and I think you should. But I wouldn't go running after, hey, I'm going to fix your pulmonary hypertension by fixing your AHI. I would go after, I'm going to fix your pulmonary hypertension by fixing your oxygen desaturations at night. Because hypoxemic vasoconstriction is a big problem in pulmonary hypertension. So every single time you're dropping, from 95 to 92, is that a problem? Maybe. Or 94, 91, maybe. Going below 90, probably. All that stuff. That's what I'd be trying to fix at night.
So,
Like somebody being off.
And there is a correlation between that.
so theoretically, some patients, they're like maybe 68, but the sleep apnea is like positive for like apneic episodes. Who get to like reach the point that they should like.
Oh, if they have pulmonary hypertension already?
They don't have pulmonary hypertension, like rather young person, they're not sure. They're like just the next step, get it to the point about treatment.
Oh, I see. And they're already fatigued?
Yeah.
Yeah, this is what I would do with that patient. I would say, listen, you're fatigued, you have sleep apnea. I can't guarantee you that your fatigue is due to sleep apnea, especially a young person. There could be a million other reasons, depression, endocrine problems, a high diet. Not sleeping enough is probably the most common cause of sleepiness in young people. So for that patient, I would say, why don't we treat your sleep apnea first, and let's see if this fatigue gets better. Then we'll go after other things. Yeah.
Patients sometimes on some services, or we can always check the AHI, like in the morning or something. So is that
Are you talking about on CPAP, on the residual AHI on the CPAP?
Yeah.
Yeah, that's good.
that's actually real?
Oh, from this device?
Like a like yeah.
Yes, that's real.
That's real.
That's real. Yeah. Oh, yeah, that's real.
Okay, so
Checking that to see if the device is supposed to be not like a
Symptomatic.
symptomatic value.
No, you still got to ask the patient how you feel. Because like I said, you can have the patient who comes in to see me in a month. I've completely fixed their sleep apnea, and they are none the better. Right? And that's when I say, go to your primary care doctor.
Yeah, we
You
need a
see?
break now.
Yeah, have a break. What is the master clock of the brain? Not you. Yeah. What controls circadian rhythm? The pineal gland? The pineal gland produces melatonin. It is also very, very important, but it's not the master clock. The master clock is something called the SCN. See, this guy is gonna know it. The suprachiasmatic nucleus. All right. Now, this little piece of your hypothalamus, it sends signals to basically the entire body, and it creates what we call the circadian rhythm. Circadian rhythm means based on how much light enters our retinal ganglion cells, goes through our optic tract and chiasm, and eventually makes it to the hypothalamus that controls whether we feel sleepy or awake, sleepy or awake. Interestingly, it also controls what hormones are being released, and those hormones and those molecules and those peptides control whether you go into REM sleep. So during the day, you might not get any REM sleep. You might just be in this light stage of sleep every time you take a little cat nap. And in fact, throughout the night, in the beginning of the night, you have more deep sleep. In the morning is really when you have your intense REM sleep. And that's why some days you wake up and you remember your dreams. But when you wake up in the middle of the night, you might not remember anything because you haven't had any REM yet.
And the REM periods, I remember something about like at one point your REM is longer but happening like less easily, and then like is it that earlier in the night like you may have like a longer period of REM or
Early opposite.
less, and then it gets longer and longer and you go into it more easily
Yes.
as the night goes on. So you need that duration.
Yes.
Okay.
So if you look at an 8-hour cycle, that's just what our brains have evolved into. You have a little bit of REM in the first cycle, then a little bit more, then a little bit more, then a little bit more, and like the last cycle, it just goes NREM, 1, 2, 3 REM.
Oh, I was just thinking for like shift.
Oh, baby, this is tough.
That, I don't think that you're still getting like 8 hours of sleep, but at a different time in the day. So I'm having like a hard time.
Listen,
Analyzing why that was different.
it is. It is. Shift work is very, very different. Shift work, it's very hard to get all of the REM sleep and the deep sleep that you need. And that's why shift workers, unfortunately, and they keep our country going. Shift workers, unfortunately, have worse mortality, worse cardiovascular outcomes, worse everything. And we think that has to do with the fact that they do not have the same processes no matter what. Unless
Right, they're still like, set up for that's all.
unfortunately, that's what our data seems to show. It's very hard to be a shift worker and get a full 7 or 8 hours, and that's because of light. Okay, light here goes to pineal, says stop making melatonin, goes to SCN, says hey, release all of your good wake hormones. Darkness tells pineal it's okay to release melatonin. It tells your SCN now it's time to take a break.
Two questions. What's the long-term health effects of us doing 28 hours?
Yeah. Died on DNR. Like I would nap in my bunk bed for like 2 hours and then walk into the home. You know what I mean? Like that's not good for you.
You got it to 11:30.
Yeah. Okay. Oh. Thank you. The negative effects, I don't know. I mean, short term, you guys are already feeling those. Long term, all of these things are. It's kind of, I think of it like your patient with atrial fibrillation who is on a blood thinner. If they or don't take the blood thinner or their INR is 1 for a week, are they going to have a clot? No, because the overall risk, the yearly risk is like 2.4% event a year. And then if they don't take a blood thinner, it might be 4%. I mean, it's not a daily thing. It's if you have long-term shift work forever and ever and ever, we think that leads to a problem. I'm talking years and years. This period is not going to kill you.
Unless you also get a big 6 years for fellowship and you're gonna trap multiple children in there and like could still the future's bleak.
Oh, yeah, yeah. great question. Unfortunately, we don't know the answer to that. There are, so how many hours of sleep you need is a bell curve. And there are people that are normal at the edge of these bell curves. So, you know, 2 standard deviations out, you got these people right here. And we call them short sleepers and long sleepers. There seems to be a very, very, very small percent of the population that can be perfectly fine with 4 or 5 hours sleep. And there are very, very small percent of the population that are normal, but they need 9, 10 hours. Most people fall into that. So I would say to the people that are saying, hey, you know what, I do good on 4 or 5 hours of sleep,
Could be real.
it's probably the fact that their body, using all of the other processes, is able to compensate for how tired it is. But if I was to actually do a motor vigilance test on these patients, after 7 hours of sleep versus 4, I bet you the 7 hours would feel better. Because we all have, go ahead. Well, I was just going to say that we all sleep a little bit sometimes and feel like, oh, yeah, we're doing okay throughout the day. But how do you define okay? What are the objective measures we're using to feel okay? Or what are the objective measures to feel that we're fully functional? Unless we do a test, we're not really.
It's all relative too.
I'm curious, I have a follow-up question because you cited a study about like making people sleep an extra hour. Like, can you expand on that?
Yeah, I would say that most adolescents and college age people are generally not sleeping enough. And that although they don't feel sleepy at midnight or 1 or 2 a.m., if we put them into bed and this is in a controlled research setting, we put them in a bed, turn out the light, give me your smartphone, no TV, guess what?
I do that to my son every day.
They fall asleep.
About so on this subject, so I feel like there's like a lot of whether or not you have it, right? So
Oh, nice.
8 hours, but then you did 8 or got 4. I personally feel like I could really be careful on it. And then I need to do that twice and then does that do anything for me? Is that normal?
Yeah, that is normal. It turns out that every time we sleep deprive ourselves, we gain a sleep debt. I don't think I've heard of this term, sleep debt. But to pay off that sleep debt is actually not a 1-to-1 ratio. One night of missing sleep, probably you need weeks to catch up.
Oh, no.
Travel, right? Like we have a 3-hour difference. Yeah. If you like go to the other
Right?
side of the world, 12 hours different. Maybe 12 minutes to get that.
But remember, don't be so disheartened by this. These are you know, 1 or 2 nights. These happen sporadically. It's really not a problem. All of this stuff is long. Like for example, you might have had a night of drinking, and you suppress your REM that night. Who cares? You're fine, right? But the alcoholic who then has withdrawal symptoms, that becomes a problem. But he's been doing it for years. All right. Even if you were to binge drink for a month, you probably wouldn't go into DT. You have to suppress your system forever and ever and ever. And it's the same thing with this. Acute sleep deprivation, missing a couple of hours every once in a while, you know, when you have children, these kind of things happen. And you just have to get by, but don't be so disheartened.
I really resonate with that. I'm an 8-hour sleeper, and on 28th, my full rhythm was completely off.
Yes.
And I have to drink so much coffee, and then it stopped working.
So
Yeah.
I remember that phone call we had. I just drank like 2 cups of coffee, which is double my daily dose. And it was
I totally is true. I do the same thing. I take it 1 in the morning, in the afternoon, that's hot, never morning.
Yeah.
What are some good like daily things in your experience?
We can't do like a heinous doctor, you know, just stay late for our surgeries and stuff.
Okay, I'll give you a cheat code. All right, if you can do it, you take a cup of coffee and you just pour it over. No, okay, no, you take a cup of coffee, you drink it, you close the lights, turn out the lights, and you get into bed. Put your alarm clock on, half an hour out. When you wake up, you got the coffee finally kicking in. You've had a half-hour boost. You're good to go. It's the best way to pump your things up. So, for example, I mean, I have a lot of truck driver patients that work for DOT. This is my advice. Go to the truck stop, grab the coffee, drink it as fast as you can, close the light, put on an eye shade, go to sleep. 45 minutes, half hour later, wake up, you're feeling a lot better. And the coffee's going, you're good. Otherwise, you know, there isn't really any tricks. You just have to get sleep.
Yeah,
Yeah.
that also suppresses.
Yes, exactly.
Get into like, can you have a random?
Yes. Instead of withdrawal, yeah. We don't call it DTs for some reason, but they have crazy withdrawal symptoms.
That's like psychosis, it could be similar to like a DT, like physiology.
Yeah. This hasn't exactly been called DT. DT seems to be for some reason only referred to alcohol withdrawal, but amphetamines absolutely suppress your REM.
Does caffeine, like when I take caffeine pills, 28 hours, if I were to, not saying that, does that then suppress my REM? No.
Now, the way caffeine works is caffeine is an adenosine antagonist. Okay, so caffeine gets into your brain, and over the day, think of yourself carrying like a backpack, and you're building sleep drive throughout the day. When you move your muscles, you break down ATP, and you make adenosine, right? Once you've gotten rid of all of the phosphorus or phosphate, whatever it is. As this adenosine builds up in your backpack all throughout the day, that's when you start to get sleepy. Adenosine molecules start to make your brain start to feel sleepy. They suppress awake, and the sleep drive comes on hard. Caffeine is holding that back a little bit. That's how it works to suppress sleep. You can be way more sleep deprived, and caffeine won't do a single thing for you. Okay, because unfortunately, it just will. Your sleep drive is going to overpower you. Yeah. We would be remiss not to touch these things. This is called a CPAP. And this is a mask. So this is the reverse vacuum, right? We talked about it. Who was that guy? So Sullivan. Palen Sullivan. That's right. Australian guy. And then William Dement is the father of sleep medicine. Excellent. Good job. Yeah. and who invented the EEG? Berger. Good job. Hans Berger. That's right. Well done. Okay. So, yeah, so this is a CPAP. This is an older model called an S10. We have an S11 that looks just doesn't have this button, and everything is digital now, but doesn't matter. They all work the same way. They suck in air through
The vacuum plan.
this filter. Yep. This filter, and then it goes through this tubing you see here, and eventually comes out here into that tubing, and you can just easily plug that tubing in. Then it connects to some sort of a mask interface. There are hundreds of different types of mask interfaces. There are lots of companies that make mask interfaces. And your whole goal here is to somehow get this into the patient's airway. What is the optimal way to deliver this therapy? Would you say it's give it through your mouth, give it through your nose, or give it through your nose and mouth? Both? Nose. Why?
Not sure.
Your nose humidifies. and
That's
cleans
right.
out the air, so you don't
There's that.
more contaminated mouth because you're not filtering.
Not so much about contaminants, but dry mouth is a big problem. But you have turbinates that are natural humidifiers. They're going to do that. But more important, can I borrow your pen
Of
here?
course.
So you got your little nose here, and then your lips, and then your whatever, and then your turbinates, and then your air, and then right here, what is this thing called? This is your hard palate, and then right here, you got a dangly. This is called your soft palate, and this is called your uvula, right? With me so far? And then what's this big thing called? Your tongue. So where is the obstruction, the most common source of obstruction in obstructive sleep apnea? That's what I would think too. But it turns out it seems to be this retropalatal collapse. It seems to be a combination of this soft palate falling backwards, like this, and the tongue also falling backwards.
So should we sleep on our fronts? My front sleeper.
Prone sleeper?
Yeah.
You can call it front, but we can use
Say dumb stuff. A
Children-
prone sleeper.
children naturally tend to be prone sleepers. And you can be a prone sleeper too, but certainly sleeping on your back is going to make sleep apnea worse. That's why most bed partners will give their partner a jab, so they turn over onto their side, and all of a sudden snoring gets better. And what you're relieving is this business right here. So that's why if you have to give, ideally your first choice would be a nasal airway or a nasal interface. And not only the humidification, but also it just works better for direct flow and relieving this possible obstruction, which is the retropalatal collapse. Additionally, if you were to put pressure right here on your chin, which is how this mask, yes, it pushes all that stuff in. So that's also worse. So oftentimes what we'll see is patients need a little bit higher pressure when they go
You
to
should really like trial different ones if you're the patient. Like you
Oh.
really should like give it like at least a few different 3 and
yes, most of my
like at least nose only, at least both only. Because like depending on whether their anatomy is like closing here or here,
nailed it.
be like totally useless or actually useful.
Nailed it. I mean, that's exactly right. The most common reason that patients don't continue with CPAP is usually a mass discomfort problem. And so you just tell them, hey, we're going to try this, we're going to try that, and then
Discomfort, but also like
not really fixing things. Yeah, yeah, exactly.
Can I ask a practical question while we're about that? So my sister happens all the time. I just say, I hate my mask. It's not fitted. It's old. What are the best way to get them a different mask?
At the VA,
Outside.
outside of the VA. So here's what happens. The VA is easy. The VA is just a message to your friendly sleep medicine doctor, and at the VA we don't have stipulations, but outside of the VA, the way all these, this machine costs like $1,600, right? And these masks might be like $50 or something like that. If you're not at the VA, your insurance company pays a DME company, durable medical equipment company, and they are the ones that will supply you with this, and then your medical insurance company will pay that company. Your insurance company will only pay for a new mask every 3 months.
Oh, wow.
So if you're a private insurer, or if you're privately insured, you might have a problem. You might have to wait 3 months. You could buy these on Amazon. You could buy them on cpap.com,
love that.
which is a very easy place to look up masks, and you can find all these different types of masks. And it's okay to direct your patients to that and say, hey, pick one that you might like. The other thing I would think practically for you guys is you might run into patients with beards. Oftentimes when you run into patients with beards, this silicone material, it really doesn't contour a beard too well. And it can feel a little bit not nice on the hair. So we have We don't have it here, but doesn't matter. We have a mask that is a memory foam mask.
Oh.
All right. So it feels kind of nicer on your face. It definitely feels nicer on the bridge of your nose, but it contours the beard, creates a much better seal for those patients. And we have those in a nasal mask. This is called a nasal mask. This is a full face mask, and then there is a nasal pillow that is not here.
I've seen that for the first
But you guys have seen nasal pillows. They look like nasal cannulas, but nice round. So
Can I
yeah,
add one thing about the practical thing about outside? Beginning of the year when they haven't necessarily made their deductible is oftentimes where they might have to pay more out of pocket, sometimes depending on the insurer. And then also, I tell in primary care, I suggest that people talk to their vendor directly because it's in their interest to make sure that the mask is fitting because they get paid more and all that sort of stuff. And that's oftentimes faster than necessarily sending a message to the sleep medicine person who then has to go to the vendor. There's a way to shortcut that that's often faster.
oh, hey, thanks so much. Wonderful. Nasal pillow. So, the majority of patients get this as their first. Like if you just had to pick something empirically, this is what you would pick, a nasal pillow. Pretty comfortable. Works directly on that area. Oftentimes with this, you might have a patient who comes in and tells you, I keep waking up with dry mouth. And then you might look on the machine and the patient will say, I keep seeing a sad face on the machine. And then you might look at a download if you guys ever look at downloads and see that there's a high leak. And the reason is that the mouth is opening up. And so you can still use this, but you can just give a patient a chin strap, an elastic chin strap to keep their jaw lightly closed. And that's a very easy thing. I think it costs like 20 bucks. We have it at the VA. DMEs will have it too. It's very easy to get, not a problem. But opening your mouth at night is actually makes sleep apnea worse. And the reason that happens is think about your thyromental distance. Mental being chin, thyroid. This is where your tongue is sitting. Now watch this. Open your mouth. Did you decrease that? So your tongue has less area and all of a sudden falls further back. So it's in your best interest and the patient's best interest to keep your mouth closed.
And for other reasons, they're not necessarily apneic. Probably better not to.
Other reasons I can't really tell. I mean, sore throat. Sometimes people will wake up with a lot of uveitis. So you might see a patient in clinic and their uvula just looks like this red giant punching bag. That's a pretty good sign the patient is probably has sleep apnea and is opening their mouth at night. And that'll just get better by itself. But the reason is that they've been going like this. And they're sucking in so much air and it's so dry. And that thing just gets more and more and more drier and more inflamed as it vibrates and hits the back of their throat.
So what's the best sleeping position then? Back
Lateral.
to, okay.
Lateral or prone?
I've always heard it's like sleep on your back. And I'm not sure.
Non-supine.
Yeah, but interesting.
And then another way to help your patients. Okay, so go back to the 70s with me. What was the way we treated sleep apnea?
The back.
Tracheostomy.
Tracheostomy.
The patient that said no to tracheostomy, how do we treat them? We told them to sleep sitting up. Okay, sleep sitting up or in a little bit of recliner. Why does that help? Gravity assists you here. So when I sleep sitting up like this, my belly flops out rather than in and up. My diaphragm has more room. My lungs have more air. I have more tracheal tug. And I'm not lying down like this and my tongue's not falling backwards, it's going like this. So your patients that we're still trying to figure out their sleep apnea, we're still trying to make them breathe better. If you want to give them a little bit of a tip, you could tell them to sleep either lateral, you could tell them to sleep with a on a little recliner. In fact, your patient will even come to you and tell you, you know, doc, the best sleep I ever get is when I'm watching the nightly news and I just fall asleep on my couch. And it's like, well, yeah, you're not having sleep apnea during that time. That's another trick you can use. All right. What are we at time-wise, guys? Right. Okay. So, any questions about what we got going on here?
Well, it's just some kind of an adapter of sorts for something.
Hey, you're not gonna believe it. I don't even know what this is.
I think it's to bleed in oxygen, right? Is that what that?
Yeah.
Oh, is it bleeding? Okay.
Where do you plug
Can you come show us this? Thank you.
You'd like to, the adapters go in the back,
Yes.
the port here. And then your tubing. is,
Yeah. Then you
Now, yeah, there are dedicated tubings with already a port that you can purchase that we can order for veterans instead of this one. This one is pretty old school, but it still works.
I'm sorry, I didn't get your name.
I'm Michael.
Michael? Hey, Rahul. Hey, nice to see you. Yeah, thanks. Thank you so much. Yeah. So oxygen at night. There are lots of trials going on to figure out who really needs oxygen. You guys might have been following this, right? Back in the day, a lot of patients with COPD were put on oxygen. Now we're trying to trial that back. The same idea applies for nocturnal hypoxemia. We're not actually super sure about who really needs oxygen at night. So this is not a common thing that you'll see unless we have a really, really strong indication, which is I can't fix your hypoxemia even after I fix your hypoventilation and even after I fix your sleep apnea, but I have to prove that in an in-lab sleep study. That's the only way insurance will pay for it. In-lab sleep study showing that PAP, any kind of PAP, does not fix your hypoxemia. And it has to be hypoxemia 89% or below for 10 minutes throughout the night. Then you can get O2 in.
And some of the other groups are also trying on the mask. We just can't pass from person to person
Oh, do you guys? Oh, yeah, please.
for obvious reasons.
try.
So wait, do they try them on?
Are we letting them try it?
They can, I think.
As long as we're not passing. Yeah.
That's not a wipe it off.
So we wipe it and then we put it on our face?
Let me know and I'll.
I don't wanna know.
Oh,
So don't try these on.
We're not trying.
no, not these.
Is the length of this tubing just for patient comfort? Because it seems kind of physically, from a physics standpoint, it seems that I can.
Yeah, you're right. This is mostly because we don't know where your nightstand is going to be and where you're going to end up placing this thing. And but I agree with you. It's a little ridiculously long. Yeah. Yeah, let's do it. Definitely. Yeah.
Mhm.
How do you decide that in the outpatient?
Okay. So let's talk indications for bilevel. The primary indication for bilevel is hypoventilation. Hypoventilation is defined as anybody that has transcutaneous CO2 or end-tidal CO2 greater than 55 millimeters of mercury for 5 minutes. Okay, that's nocturnal hypoventilation. What is daytime hypoventilation?
You have new ones here, Doc.
Oh,
This is
thank you.
a top of the head connection.
Oh yeah,
And
yeah,
if
yeah.
anybody
that's
wants
cool.
to turn it on, I can have a filter here.
Yes.
I don't think we're allowed to turn it
Oh,
on.
okay.
Yeah, unfortunately.
But you can feel it on.
Oh, okay.
You are?
You can feel it on, but not turn on that positive.
But put this on your face. I'm allowed
not
to?
Yeah,
put
those
air
are, those
through
are
it.
both new, so.
Okay,
If you want to put it on your face, you
Sense
can,
of,
but you're not
yeah.
allowed to put air through it, apparently.
Yeah,
I understand now.
And the reason for that is like,
then we'll be blowing the
if,
air around.
if you put air on her, this positive pressure may aerosolize her COVID,
There's white.
potential COVID.
So I can put it on my face without the mask on.
It's actually been a disruptor for our patients too, because back in the day, we used to pressurize these devices and help patients to them in the clinic. And now we can't do that. Anyways, we were talking hyperventilation.
Does it impact your?
I'm still the tightness.
Yeah, the proper fit would be, the bottom
Here.
portion of the mask would fit under
So these are
your
the
lip.
different sizes. so she
And
probably needs
then
smaller.
you put it, and measure it to the top. So right under your lip.
Right under the lip.
Not under the chin, right there. And then it should fit. Yep, that's actually
Not
not too
bad.
bad of a fit.
And then I would tighten
And
it
then just
here.
tighten up the straps. Yeah.
Right, open it, maybe.
Is it very? Okay, I want to make sure I talk to you guys about, we have to, the three things we have to hit is the Philips recall, Inspire, and, the mask recall, but, we have time. Let's hit that, let's start hitting that at 11, or sure. Oh, hyperventilation, okay, so back to bi-level, so, what is daytime hypoventilation? How do you define that? Increase CO2 during the day. Excellent. And there's a number for that. It's not actually, it's actually 45. So we say normal carbon dioxide levels during the day is 35 and 45. The classic number that we use when you guys do calculations, if you guys ever do like the alveolar gas equation or something like that, when you get into the ICU, you'll be doing all that, you'll use 40. And that's because it's right between 35 and 45. So greater than 45, you get an ABG with a CO2, PaCO2, greater than 45, you can say that the patient has hyperventilation. At night, we're not going to keep an art line in and check their blood gases, so we use a surrogate marker, and the surrogate marker that typically used in adults is transcutaneous CO2. And you put that right here, and it just basically heats up the skin. It capillarizes. By heating it up, all the blood vessels start to get dilated, and it detects CO2 using like an infrared thing to figure out what your transcutaneous CO2 is. In kids, we use end-tidal CO2, and the number is 55. So let's say you get that. Now what you do is you make sure you treat the patient's sleep apnea. Why? Because you want to make sure that the throat and the airway is completely open to allow good ventilation. If after that, you still have elevated carbon dioxide levels, now you want to give them a little bit of pressure assist. That's where the bi-level comes in. Bi-level is, I'm going to give you a certain pressure at an EPAP. EPAP is the bottom number. Expiratory positive airway pressure. And then when you breathe in, I'm going to detect that, and I'm going to give you extra pressure. The delta between the EPAP and the IPAP is called what? Pressure support. Pressure support. When you guys get in the ICU, you'll hear everybody ask you, what's the pressure support? What's the pressure support? What's the pressure support? Pressure support is the delta between the IPAP and the EPAP.
Why do they give it a fraction?
They don't give it as a fraction. They just say 15/5, just because it's colloquially how we say it. And you write it 15/5, but it's not a fraction. It's not 15 divided by 5 or anything. It's just the way we write it. You could write it as a backslash thing, whatever you want, doesn't matter.
Okay.
So they're dating them sequentially instead of putting a comma.
Yeah, if I call you and I tell you, hey, put your patient on 10/5, you would know the higher number is always the IPAP, and the lower number is always the EPAP. And the pressure support is the difference.
And this is not the driving pressure.
The driving pressure, is not a term you want to use on non-invasive ventilation. So driving pressure you can consider using on a mechanical ventilator, which is invasive mechanical ventilation. But not on this. You don't want to think about that. Yeah. Okay, so this is when you would use bi-level. You would use it to treat hypoventilation. And what I would do is in the sleep lab, I would monitor their carbon dioxide levels. I would put them on a pressure support. The standard pressure support you would start somebody on is 4, and then you just go up like that. So I would say, all right, at a pressure support of 7, I've gotten their carbon dioxide from 55 to 50. That's not bad. And now I know that I need at least 7. And that's the setting I would put the patient in. Because the more pressure support they have, the more ventilation they have. Okay? And one thing to also note is you don't want to breathe somebody down to 40. At night, everybody's ventilation goes down at night. So everybody at nighttime when they're sleeping go down to about 47, 48. That's fine. That's normal. That's why we say abnormal is 55.
So bi-level fixing hypercarbia.
Yes.
CPAP is purely like obstruction.
Yes. In some patients, just a CPAP can even fix their hypercarbia because their hypercarbia was happening because they had so much apnea that they weren't even exhaling CO2.
So you'd usually start with CPAP.
Always.
See if that helps. And if it's not helpful, then you can try bi-level and mess with the amount of pressure sometimes they don't need to get their CO2.
Always.
This seems like you would need, so in sleep medicine, do you actually like do more monitoring? Like, are the people doing this at home and like bringing in their numbers? Like, how are they actually?
Well, everything is remote monitored now, so
Do you just
these-
remote monitor it, review it, and then adjust at the next like visit or something?
yeah.
Okay.
I
I have a left field question.
Yeah.
Can you help me like replace obesity hypoventilation syndrome with sleep apnea in some way?
Yes, of course.
I know that's a very big question.
Yeah. So almost everybody with obesity hypoventilation has sleep apnea. It's the rare finding that you'll have somebody with obesity hypoventilation who doesn't have sleep apnea.
But, okay.
Not everybody with sleep apnea has obesity hypoventilation. Obesity hypoventilation is defined as BMI greater than 30, daytime PaCO2 greater than 25. So
Okay.
you got the obesity, then you got the hypoventilation, and then remember it's a syndrome. So that means you have to have those two things and symptoms. So symptoms of sleepiness, I wake up with a headache in the morning, I feel so miserable in the morning, I'm kind of sluggish throughout the day, and now you've got your syndrome.
Okay.
Now,
So you could have like, somebody with obesity who like didn't have the daytime sleepiness, but still has the obstructive sleep apnea. And then that person would not have like obesity hypoventilation syndrome, but if they then ended up having also the fatigue and the things you just said, then we put them in that category.
yes,
Obesity hypoventilation syndrome.
yes, and then your next question should be, how can fixing somebody's sleep apnea or hypoventilation at night treat their daytime problem?
Well, they sleep better.
Yeah,
I don't know.
yeah.
I don't have a good answer.
It's like how is it these obesity hypoventilation people, when you're obese, you kind of have a restrictive ventilatory effect, right? You have so much mass on your thoracic cage, it's hard to move it. You have so much mass here pushing up your diaphragm. Ventilation is not very efficient. So you're going to retain CO2 throughout the day. Well, at night, we're going to help your respiratory muscles so they might have more energy during the day to compensate for that ventilation. How does a person that has low lung volumes keep up with their CO2 production?
Right, increase their respiratory rate.
Exactly. Now, when you increase your respiratory rate, if you guys were to go, you'd probably eventually tire out. And that's when you would start having the hypoventilation.
I see.
But if I give you rest at night, if I help you out at night, you might make it more throughout the
muscles and things. Right. Okay, that makes sense.
And you know, all of these patients, they also just tend to make more CO2. They tend to eat more. When you eat more carbohydrates, you make more carbon dioxide. And comes a problem like that. So you have to get rid of it faster. So you also have to go. Oh, I do not want to get into nutrition.
Lives.
Okay, so you got your CPAP. You figured out why you want to use bilevel.
Or off without, with or without oxygen.
Do we need to discuss BiPAP ST? I don't think so. Okay. So let's move on to alternatives for CPAP. And let me know when it's 11. At 11, we need to talk about Philips recall and Inspire.
We have 10 minutes.
10 minutes to talk about alternatives to CPAP. Okay. So my awesome diagram is this way. Okay. So you got your tongue here. So when we are, and if you think of this airway like a straw, we're going to blow air through the straw to keep it open with a PAP, right? An alternative way is that we can just kind of keep the straw taut mechanically. So if I was to grab your chin and pull it forward, I would essentially be pulling all of these muscles forward. The upper airway dilator muscles most of them are attached to one bone called the hyoid, which you guys might have heard of. The hyoid is like a free-floating little bone here. When I pull this jaw forward like this, I yank the hyoid forward, which pulls on the dilator muscles forward, and I'm going to keep your airway open. So that is an alternative to CPAP, and that's called a mandibular advancement device, a MAD. Alternatively, it's called a oral appliance. This is an over-the-counter version. It's called Vital Sleep. Okay, it's over the counter. This might be like $75 or $100. The ones that a dentist makes for you, which is the one you want, is like $3,000-$4,000. Okay. And yeah.
The fancy people get the dentist one.
Yes, almost everybody should get the dentist one. This thing, you put it in hot water. This little gel area.
It's like a mouth guard.
Like a mouth guard from high school. And I'll pass this around, but you'll see these little lines here, these grooves. You pull this forward, and it will eventually keep your jaw forward. So give yourself a big underbite, and that is how people with dental appliances sleep. So surprisingly, patients, especially younger patients, go for this and they find it much better than this. Think about if you're traveling.
Just make noise.
Yeah.
No, hardly any.
Oh, hardly.
You could take this, go anywhere. You sleep somewhere else, doesn't matter. Hotel, somebody else's house, doesn't matter.
Yeah.
Also, it's not this giant thing, so, you know,
Just make the bed better.
dating life or whatever. So younger people tend to go for this a lot more. But there are caveats to this. Who can't get this? No teeth. TMJ. Excellent. And then anybody who doesn't have at least one molar, upper and bottom on both sides. Because this thing is fine, but the one that the dentist makes, it has to attach to your back molars to yank everything forward. And then the side effects of this are that sometimes when you wake up in the morning, you have a little bite, like your bite is a little offset. And so your dentist will then give you something to reset the bite you have to wear in the morning for like 30 minutes. Oh. It doesn't happen with everybody, but it's something that we should be aware of for side effects wise. And the other side effect would be, this is why we always ask for TMJ, is you wake up with a little bit of pain because you're stressing these muscles. So that's why a dentist always starts at the lowest rung and then eventually transforms it. So this is This is in millimeters. You'll start at 3 millimeters, and the highest you'll probably go is about 10 millimeters. And this is a reasonable alternative to CPAP. Technically, it's for patients with mild or moderate obstructive sleep apnea, but we've already kind of poo-pooed that. So what I would say is, if your patient cannot tolerate CPAP and they've got their molars and they don't have TMJ issues, then this is probably better than nothing if they're symptomatic. Okay?
So at the VA, dentist is not free unless it's 100% service connected. But if you need to get this done, is that, like, does that qualify them under service connection?
Yeah, although it's a little bit tough. You don't even need a service connection. You know, it's like at the VA, at our VA anyways, if you don't have a service connection for sleep apnea, I'll give you this machine. That's $50 one time. If your service connection, that's $0. And then all these masks and stuff, nothing. And then same thing with dental device. I don't know exactly what the copay is, but it's not a lot.
That's great.
A VA, man. Okay, so this you guys understand as a reasonable alternative. And we don't really have anything else to show here today, but one other thing I'll tell you about, please tell me at 11. One other thing I'll tell you about that is good for patients with mild obstructive sleep apnea is something called the Excite OSA. Have you guys heard of that? It's a tongue stimulator. Okay, so it's a little device you put on your tongue. It's the first daytime treatment for this nighttime problem. You put it on your tongue, you sit there for 20 minutes. And if you've ever been in the gym and you're pumping muscles and like you're doing a bicep workout, after that workout, your bicep has a little bit of a pump to it, has a little bit of a form to it, has some more tone to it. Same idea with the tongue. We put this Excite OSA on, we do electrical stimulation using these 4 electrodes on the tongue, 20 minutes every day for 6 weeks. And it has been shown, this just got FDA approved 2 years ago. It has been shown to treat mild obstructive sleep apnea. That was the only population that it was studied in.
And does it matter what time, like, do you have to do it like before night to like get your pump on? No, it's just strengthening those muscles.
Yeah.
Time. Interesting.
Yeah, and the only people that shouldn't get that is anybody with piercings, implants, or metal crowns.
Oh, you're worried about shaking them loose.
Not shaking them loose, but you're heating up this area that's full of saliva, so you probably those things will start getting hot and not feel very good because you're putting electricity on your tongue.
Basically no metal in.
Yeah. Although I have a lot of patients with fillings that don't have any problems. Yeah, crowns mostly. Yeah. Like yeah. Huh? You know, this is actually one of my most common treatments for sleep apnea right now.
And what is the evidence behind it? Just like stimulating the tongue, like how well does it actually work?
Yeah, so the evidence is a study done, I think, of like 250 patients that all had an AHI of at least 5 to 15. And by the time they were done with their 6-week trial, I think 80% of them had a reduction to AHI less than 5, and then almost all of them had improvement in their symptoms. So you can actually also get this just for primary snoring too. Unfortunately, this thing also costs $1,400.
Oh.
Yeah, there must be like.
What's that? Oh, I thought you were saying something.
Like all the other like anti-snoring, like the breathe right nasal strips and things that people use, and there really isn't evidence for those things either.
There is actually evidence for that. For snoring, yes. So think about this. How would you know if somebody's going to be good on a breathe right? You can actually do this in clinic to your patients. It's called the Cottle maneuver, COTTLE. And we can do it all right now. Okay. So you have a patient come in and he says he's snoring. You say to them, hey, I want you to take a deep breath. All right. Now I want you to put your index fingers right here on your chin and pull it apart. And now breathe again. It's hard to do through a mask. But what you're doing is you're essentially pulling apart your nasal valves. You see? And you're pulling, these are called the ala of your nose. And inside you have nasal valves that are formed from different structures. And when you do this, you pull it apart. And that's what a breathe right does. So if that's positive, they might do well with breathe right strip. Breathe right strips can be annoying because unfortunately, like you're lucky if you get them half the day. So it costs a lot of money. Those boxes cost a lot. So you can have your patient buy nasal cones. They just insert them like this and they keep open. But something that I found that's better, that I just started not prescribing, telling my patients to buy, is a $20 device called a nasal aid. And this nasal aid, it goes over your nose and in like this and pulls your nose apart. And it's good for like a year. My dad's been using it now for 2 years, and his snoring is treated. He doesn't have sleep apnea, but his snoring is treated.
A nasal aid.
Nasalaid.com.
Guess what my husband's getting this week?
Try it out. It's only $20. And if it works, it's a pretty good investment.
You have
Thank you.
a nose breather versus like a mouth breather for that tour.
You know,
Sorry.
everybody, nobody is solely a mouth breather. Everybody has some airflow through their nose. And hopefully, if we can optimize your nasal airway, we can make you more of a nasal breather. So there are tricks that you guys should have in the back pocket of how to optimize somebody's nasal airway. One is positional, like we talked about, have them a little bit more elevated so that you have less blood flow over here and less congestion. And a common thing is Flonase.
Yeah.
You guys have heard of fluticasone nasal spray. Now, in primary care clinic, when I was internal medicine resident, I would prescribe Flonase like candy and not ever talk to my patient how to use it.
Not that idea.
And I think it's important to take the opportunity, if you're going to prescribe somebody Flonase, tell them how to use it. Okay. Most patients will take a nasal spray, go like this, point it up, go with their nose, and go like that. And then they say it tastes bad. The area that we are trying to fix is right here, about 1.5 inches from your nares, and it's back, not up. Your nasal passages go back. I could take this pen and go straight back without a problem. Well,
No problem.
so teach them that anatomy. Teach them that anatomy. Point it like this. Say it goes like this. And tell them, take your nasal spray, point it back towards your earlobe. Breathe normally. You take a giant breath in, you're going to go past the turbinates that we're trying to decongest. Okay? And then just 2 sprays, breathing normally, 2 sprays, breathing normally, pointing backwards. Right? And you have to also remember that we are giving you a topical steroid that's very, very low concentration.
Yeah.
If they're all of a sudden feeling better, that's most likely placebo. They just like the fact that it's a little bit wet. This takes 30 days to work. All right? 30 days to work. So use it for 30 days straight. What are the side effects of Flonase? What are the bad things about Flonase? Really only one. Really only one. And that is that sometimes it can really thin the membranes.
Yeah.
And if a patient is already predisposed to having nosebleed, they've got a little, whatever that palatine artery thing is, that kind of sticks out sometimes, it can bleed a little bit. If that happens, you stop.
But you can use it long term.
Oh, yes. Oh, yes. Use very long term.
Is there any surgery that works for sleep apnea?
Yes.
Oh, yeah.
Excellent. Okay. 5 minutes on this, then we have to talk about the recall and the Inspire. So there are surgeries that work for sleep apnea. The most common surgery that you've probably heard of is called a UPPP, right? Uvulopalatine pharyngoplasty, something like that. We have a surgeon here at the VA. His name is Ed Weaver. Ed Weaver has basically created the modern UPPP surgery, and he works right here. He has written the up-to-date articles on all of sleep surgery. He's kind of a big deal. And he does a lot of these surgeries for us. And what you're trying to do is We're trying to look in the nose, look in the back of the mouth, see what areas are collapsing. And you either tighten those muscles or remove extra tissue. You'll look in patient's mouth and you'll say, oh, hey, you don't have your tonsils. Maybe there's nothing to do there. But there's also tonsils you can't see. There are the palatine tonsils that might be removed. Sometimes they do tongue of the or base of the tongue surgery, BOT surgery. That means we'll shave the base of the tongue to create more room. So sending somebody to a sleep surgeon can certainly be effective. It is rare that it cures sleep apnea. It will likely decrease the AHI, but there are many times I had patients that have had two-stage surgery. So first they had a septal reconstruction, they had turbinate reduction, then they had UPPP where they cut off the uvula, strengthened the palate, base of tongue, and they came back with the exact same sleep apnea.
Oh.
Now, we shouldn't be discouraged about that. These patients are super symptomatic. We got to try something. Okay, so there's that surgery, and then there's a surgery that I've never sent somebody for, which is mandibulomaxillofacial advancement, MMA. And that's where we fracture right here and fracture right here and pull it all forward, and with some titanium plates, and we create more room in your jaw like that.
That's what they do for kids with like microanapnea.
You are correct. But they do also do that for adults. So you can, I had a patient, I gave him that option between that and tracheostomy because he was just so poor or not so poor, but he had so many ridiculous symptoms. And I was like, we have to do something. And he refused this. He refused everything. And now all he does is just sleep sitting up. He's still miserable, but he won't go through these surgeries. They sound pretty scary.
Yeah.
Yeah. Okay, let's talk Philips recall. Philips recall, your patients are going to ask you about that. Philips recall is not on these devices. This company says ResMed. Philips Respironics is the company that had the recall. And the recall was that they have this foam lining the inside of their CPAPs. You can't see it. And the reason that foam is in there is for sound abatement and to prevent this thing from vibrating because it's got a little motor. This also has foam in it, but it's not the same type of whatever silica composite foam or whatever they had in Philips. And over the many, many years, patients started complaining that they were having cough, sinus headaches, and all this weird stuff with these. And eventually this led to some research being done. And they said, oh, this might be related to the foam. After that, some researchers started taking all this foam, particularizing it, and injecting it into mice.
Oh.
All right? With super high concentrations, and these mice develop leukemia.
Oh.
So all of a sudden, now everybody's so afraid of, and then they had like liver dysfunction, kidney dysfunction, all these million.
But they didn't like have the mice breathe in this stuff. They had.
Well, no, but it was high concentrations.
But it was
Yeah.
They breathed it.
Yeah, it was an inhalational.
Inhalation.
And they had all these problems, and so that's why all of the Philips Respironics CPAP devices, BPAP devices, home ventilators, they all had to be recalled. No patient, no actual human being has died or developed cancer or had any clear linkage to a very significant problem. Most of them have been sore throat, headache, irritation, those types of things that have all gotten better. Regardless, as you can imagine, if you've been using one of these devices for a long time, you're going to be pretty pissed off. And so we had a lot of veterans come and be pissed off. Now, our VA preferentially uses ResMed, so we didn't have as many recalls, but the new patients we inherit from other people, we had to give them new devices. And all your patient needs to do is go register on philipsrespironics.com and they'll be able to get a new device.
I guess like when I think about like an inhalation kind of issue, I usually think more about like a hypersensitivity pneumonitis or something like that where the lungs are actually like having like an allergic reaction to plastic. I guess like is there an actual like correlation with this recall to like the lung outcome or no?
No. And you got to keep this in mind, hypersensitivity pneumonitis is something that happens after many years of exposure. And at a pretty high clip. So, hey, I've been living in this house 15 years. I've got all this mold. I never knew it. or, I got these birds that I've had for 12 years and I never knew. We just discovered this business. So long-term studies may show that there's something wrong, but I haven't read anything that showed any clear diagnosis of hypersensitivity pneumonitis, which is a ridiculously hard diagnosis to make anyways, because the differential diagnosis of somebody that has a lung pattern of hypersensitivity pneumonitis is like this long. Questions about recall? Okay, good. While I'm on recall, I'll tell you this thing right now, because this is the newest recall.
Oh.
Magnet. Oh, it's brutal. So it is so convenient.
So what they don't, what happened? Somebody tell me, I don't know.
You tell me.
I don't know.
Yeah.
I can't even imagine.
You see what happened was, huh?
Someone swallow it?
No. Unfortunately, what happened is that in 2 patients, this magnet apparently triggered the defibrillator.
Oh.
Yeah.
Brutal. Because the thing is, so many patients love this. Now, what probably happened is that they put it right on there.
Yeah.
But regardless now, it comes with a black box warning that you cannot have defibrillator, pacemaker, and your bed partner can't either.
That's,
Oh, that'd be a good
So that sucks.
Oh my gosh.
I really don't. I mean,
Dateline.
I shouldn't say that, but anyways, that's the latest and greatest of the recall. People thought this thing was going to be a game changer, like patients that have stroke or decreased mobility, that they might be able to take this off and on better.
no,
But I don't know. I haven't really seen too many people say, "Oh, this is the greatest thing ever." That was the hope with these magnetic strips or magnet masks. Okay, who's heard of Inspire? Nobody? That is the hypoglossal nerve stimulator. Nobody's seen a commercial for that on Twitter or anything? The way they describe this device is like, hey, are you sick of your CPAP? Do you hate all this equipment? Do you feel self-conscious wearing this mask on your face? Well, how about that we just give you a button that'll fix your sleep apnea?
that.
How sweet is that? Yeah. Like every patient wants that now. Okay. But this is my little section here. Hey guys, we probably should have used this thing. We got the Excite OSA picture right there.
Wow.
On page 14, there's an Excite OSA picture. And then, oh, this is the learner guide. Where's my instructor guide? Did my stuff not make it? Oh, here it is. Did you guys get this? No. Oh, yeah, you did. Your very last page. What is Inspire and how does it work? Okay, so look at this. Look at this right here. This diagram on the back page. All right. You'll probably start seeing patients ask you about it because it's so heavily advertised now. It's crazy advertising. They think that it's going to be so easy. I'm just going to push a button. I'm going to go to sleep and everything's going to be just golden. Here's how this thing works. I put a pacemaker right here. I take a little lead, tunnel it inside, and I grab the hypoglossal nerve. The hypoglossal nerve primarily stimulates what muscle? Tongue, the genioglossus. And so I'm going to stimulate that muscle every single time you breathe. I'm going to give it a little buzz, and it's going to contract forward. Okay? Then I'm going to take another little sensing lead, and I'm going to put it in your intercostal space. And I'm going to detect thoracic cage movement. Every time I detect thoracic cage movement, I sense it, and it sends a little ping, and the tongue moves forward. And that is a sleep apnea treatment. So, there are lots and lots and lots of things we have to think about before you can refer a patient for this. First, patient has to have the right anatomy. We talked about all the different areas of collapse. When we look inside of the airway, we look at it from the top down and we look at it like this. Okay? Can you imagine that? I don't know, you guys will eventually do bronchoscopy maybe, or you'll watch it. When we look down, we look at it like this. Um, does the airway collapse concentrically, where all of a sudden I've got the palatal pillars collapsing on themselves, the tongue is collapsing, the uvula collapsing? If you've got that, where you've got what we call concentric collapse, is stimulating your genioglossus going to help? No. But if I just have what we call anterior posterior collapse, where the genioglossus is falling backwards, then this therapy might be for you. So we do what's called a DICE. Not we, but an ENT. A DICE is drug-induced sleep endoscopy. We give you propofol, watch you sleep, if you call that sleep, and we see which way does your airway collapse. And if it collapsed anterior posterior, now I can refer you to an Inspire surgeon. Not everybody does this. There's 2 people in our local area that do it, not at the VA, not at University of Washington, private practice people.
Are they gens? What are they? They're ENTs?
All ENT.
Yeah.
And then you go there, you have the surgery done, you go home, 45 days, you recover from the surgery, you come back, and they slowly ramp up the voltage to the point that you can't tolerate it anymore. And then we come back from that. So now I figured out your threshold for voltage. Now you go home, you go to sleep, you turn it on, and now this thing is moving every time you breathe. The studies show that there is at least a 50% reduction in AHI for most patients. You have to have at least moderate or severe sleep apnea. So moderate or severe being AHI greater than 15. And because of the way the study was done, you have to have a BMI 32 or less. Don't ask me why. Yeah. Don't ask me why they chose that, but that's what the original trial. It's called the STAR trial from 2014 New England Journal. And that's what they used. And so that's what kind of
non-obese people are not,
obesity is technically 30,
but
so
mostly.
but not too obese, I guess.
A lot of people would be excluded. Yeah.
Oh yeah, the BMI takes care of a lot of people. There are some surgeons now accepting 35, but you know, the reason I really wanted to talk about this is I think you'll have lots of patients come and tell you that this is like the end all be all. This is the panacea. This is what I've been waiting for my entire life. It's going to fix my sleep apnea. They don't understand that it's a surgery, that it's 100% not going to be as good as CPAP. Every surgeon will even tell you that. It's just not. And that's something important for you guys to know, that it's a process. Oh, and then also you can't have an MRI with it. Sorry.
Oh, no.
That's not good.
Oh, the cost of this, 40 grand. Yeah, but like, you know, when you're a company, like for example, I was actually leading the push for the VA to get this. And the VA was going to get a bulk contract. So it would be like 12 or 15 grand for the VA. And most people are like that. They have like bulk contracts. You'll do so many patients a year, so we'll give it to you for a. It's very, very involved because for each of this process, there is an Inspire rep there with you. Day of the surgery, every single time you come to clinic, they're there. They've got their little iPad and they're plugging things in. So it's very, very resource intensive.
Can I bring up 2 questions from this just to make sure that they're covered? One is Medicare rule about adherence. And then the second one is about how to advise about cleaning and replacing equipment. Cleaning, sterilizing, and replacing equipment.
Yeah. So you know these Medicare rules, this was also just done by a couple of people in a room. This was the beauty of sleep medicine back in the day. You could just get in a room and do it and decide that this is because hardly anybody was practicing sleep medicine. And so these Medicare rules are like from 2001 and they just haven't changed. And they just said, hey, we want you to use it at least 4 hours a night for at least 3 out of 4 weeks. So it became 4 hours a night for at least 80% of the nights in the last month. And they said, if you do that, then we will continue to pay for your device. And if you don't do that, we're going to take it away. So you have a 90-day period from the day you get your CPAP. And in those 90 days, you have to have a month that shows that you were able to use it 4 hours a night for at least 80%.
So to document that basically.
It's not, yeah, I mean, this thing records it by itself,
And who has access to?
the doctor.
Right,
The
so
doctor and the DME company can both see
and
it.
the-
Yeah,
It's a communication that happens. It's a wireless or
Yeah, yeah,
wireless
modem, yeah.
modem.
but I mean, in terms of coverage from Medicare, we have to document.
Yes, in your note, of course.
Right, of
Yeah.
course.
In fact, there's two requirements. One is that there's a face-to-face visit, which has now been modified to it can be also a telehealth visit within 90 days, and the documentation of 4 hours, 80%.
Interesting.
And then if you work for DOT, Department of Transportation, it's similar. We just adopted that. But at our VA, if you get this device and you never use it, we can't even take it back.
Really?
Yeah. So we've got about like 25, 30,000 patients at this VA using CPAP.
It can't be cleaned or what,
I
right?
don't know,
That's just government.
one of those VA things.
The government.
Yeah, sorry, I think I
No, no,
didn't
that's
do a
okay.
lot of the,
And then the question about replacing devices and cleaning devices comes up in primary care.
yeah, good. So cleaning devices, this is very, very easy. A lot of patients will come to you and say, hey, I can't deal with this thing. I mean, do I have to get like a pipe cleaner? Do I have to do like all this stuff? It's rural. What is going on? Cleaning this thing is very, very easy. Okay? Soap and water. Soap and water once a week. Take off your tubing.
Can you put it in the refrigerator?
Take off your humidification chamber and fill it up with soap and water. Run soap and water through this, and once a week, and then take your mask and make sure you use your thumbs and get off all of the mucus, the sweat, and the moisture that degrades this thing. So this is really the part you really want to work on with your hands. You just do that once a week. I have patients that take this, and this into the shower with them every Sunday. Clean it up there, hang this over the shower rod, put this down, come back, pick it up at night, you're done. It's like a 15-minute thing. In this thing, you're supposed to only use distilled water. If you use regular water over time, you might see like a pinkish mineralic deposit on here. If that happens, you just take some vinegar, 1 part vinegar, 2 parts water, leave it in there for 20 minutes, and it'll come off.
How do we get people into sleep medicine faster?
Yeah.
I have a patient who was scheduled for April 2023. This is last year of November.
Would you press line like that?
This is good. This is good. Okay, so if you, there aren't really any sleep medicine emergencies. But if somebody is like very, very distressed, we have 8 doctors, 3 mid-level providers, and then lots of nurses. So and we have respiratory therapists. Most of the time it's like, I have to get a different mask. I can't breathe with these settings. We'll have somebody contact them quickly. They don't have to wait for an appointment. So that's pretty easy to do. You can give them our phone number. I can give you our phone number, 253 583. Yeah, 3221. Oh, yeah, this is VA. At University of Washington, if you wanted to get somebody in sooner, best thing to do is call the sleep fellow and just see if you can't just help the patient right then and there from the sleep fellow. Most of these things can really be addressed over the phone. So a lot of quick things, you know, like, hey, chin strap, hey, new mask, or hey, we need to change your setting. Let me look at your download real quick. I'll send it settings over right now.
Nice.
You see, quick things. But if it's like, hey, I haven't been sleeping at all for 10 years, it's not an emergency. Like we'll see you in clinic. That's going to take about an hour. Insomnia is a tough one. Insomnia is really fun, but it's tough.
So for like machine questions, though, just kind of, so, fellow, get the download, so the fellow, call the fellow.
Yeah, or just give them the number to their clinic or a respiratory therapist and they can get taken care of then too. Yeah. Oh boy, I'm probably gonna get in trouble for not doing this thing.
I think we'll get the answers too. So I like it.
What's that?
I think you hit everything.
Oh, I did.
It's not like there's video evidence.
Oh yeah. Hey, sorry about that. I'll leave this here with you guys.
We'll share the both the answers and the learner test.
Okay, good. Perfect. Okay, so let me tell you this. Let me give you this example. Your patient wakes up, or your patient comes to you and says, "You're not going to believe what I did last night. I made a peanut butter and jelly sandwich, and then I put some ice cream on it, and then I put some nacho chips on it, and I ate it, and it's disgusting. And I wake up feeling so bloated, and I don't know what happened. What is that? That is a real disease. Patient says, "Hey, I woke up last night. I went into the corner and I peed and I went back to bed." Patient says, I woke up last night and I just hit my wife." And patient says, "I wake up in the morning. I feel like I ran a marathon." All of this, these are called parasomnias. Parasomnias means abnormal movements that happen at night. There are non-REM parasomnias. Non-REM is like sleepwalking, sleep eating, sleep sexsomnia, and really any kind of automated movement that you're used to doing. That's a non-REM parasomnia. Then there's a REM parasomnia. That's when you're doing complex movements, like pretending like I'm shooting somebody, getting into a boxing match with my partner, because I'm dreaming that and I'm acting it out. In these patients, we want to see that on video. We want to see what kind of stage of sleep this is happening in and what's causing this to happen. Most of the time in non-REM parasomnias, which are very common, you'll have children that sleepwalk. You'll have adults that are sleepwalking. You'll have Roseanne Barr, who took Ambien and said she wrote racist tweets, and that was sleep. That's a real thing. That is a real thing. Ambien has a black box warning because of that, so she might have used that to her advantage. But the idea here is, in non-REM parasomnias, you want to figure out, is there anything that is causing these patients to wake up? And when you wake up in the middle of the night, we call that an arousal. And arousal is when an EEG recording goes from slow to fast really quick. And that fast little circuit triggers another automated circuit. Okay? So I wake up because I go, but when that happens, my brain triggers a circuit that I'm used to doing every day. So if every day I'm used to just waking up, putting on my clothes, blah, 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 getting in the car, I've had patients do that, and they don't remember a single thing. Your child has an arousal, and they're just used to coming into your room.
Yep.
Terrifying.
And your child is like, and you're like, and the child's not talking to you. You don't know what's going on. Sleepwalking. That's all non-REM parasomnias. And what we're trying to do there is fix what is causing your arousal, like sleep apnea, or that you're not actually falling into a deep stage of sleep enough, and you're sleep deprived, and we need to get you more sleep. That's usually the answer. Two things. Then there's REM parasomnia. That's the REM behavior disorder. In REM sleep, are you supposed to be paralyzed? So should I be boxing him at night? Yeah. Well, in these patients, if we catch that in the sleep lab, unfortunately, it portends that probably in the next 5 to 10 years, they're going to develop Parkinson's disease, Lewy body dementia, or multiple system atrophy.
Um,
So it's a pretty serious and heavy diagnosis, and it's very common in veterans. It occurs in about 1 in 20. Yeah.
Before I forget, remember there's a post survey that was the fact that you all fill out.
So that is a reason you want to do an in-lab study.
So like when someone's just like they're very confused and you're having like snoring and other things, the things, red flags, like they feel like they're having violent things, dying, all that stuff. That would be a reason.
And the other thing I was talking about is like somebody saying they kick their legs. That is something that you don't really need a sleep study for. Because if somebody tells you they kick their legs at night, or like you see a child kicking their legs at night, these periodic limb movements at night are really a sign of restless leg syndrome. Restless leg syndrome is a daytime problem. It's not a sleep problem. Restless leg syndrome is something you ask your patient, do you have the urge to move your legs? Yeah. Does it really mostly happen in the evenings because it's a circadian rhythm thing? So it only happens in the evenings. So you say, does it really happen in the evenings right before bed? Yeah. It's like constantly move them like this. Does it get better when you move them? Yeah. Does it get worse when you don't move them? Yeah. That's restless legs. It's the most common cause of restless leg syndrome.
It's actually iron deficiency?
Right.
Okay, cool.
So pregnant patients, they might start to feel restless legs. It's very, very hereditary. So you can ask, hey, did your mom have restless legs? Kind of goes through, it's more common in females. And so your mom have restless legs. Okay, well, you probably have restless legs. Let me check your ferritin. Ferritin. Ferritin greater than 50, that's kind of our goal.
So how often do you refer people and then they have further sleep study and then just like you can't find anything? It doesn't happen that one time they do it.
That's a great question. So there is a night-to-night variability in respiratory disturbance. This can range from 15 to 25% difference in the AHI, night to night.
Yeah.
So I'll study a patient one night and they're completely normal. They're like, I'm telling you, I have it. I choke, I gasp, and I all this stuff. And we do it again. The next night they got an AHI 15. So just
Send
everything,
people again.
everything is symptom based. Everything is clinical picture.
And they still require you to have
One, to get your
numbers.
attendance and like. it's usually-
I know.
Not at the VA.
Okay.
The attendance, it's.
Say your name again.
Rahul Sharma. Let's see. SHARMA. That's probably the easiest way to write it. I don't know why I'm looking at the spelling of my name. You know, SHARMA. Okay. Yeah.
Off topic, but not off topic. I just listened to a Dateline last week because that's my only. Anyway, and this guy like strangled his girlfriend in his sleep, and they was, oh no, I do weird stuff all the time. This is totally, and they did this whole like in-lab study, and he lied about it, but like.
But he used it.
But he used it
Yeah.
to murder someone, and
Yes.
said he did it in his sleep.
Yeah, there are court cases, all based on having a sleep doctor diagnose that patient with this thing called REM behavior disorder. Crimes that have occurred, and a doctor has set them free, or doctor has not set them free.
Really?
Oh, yeah. This was discovered and diagnosed in 1986 at the University of Minnesota, when it was discovered by a doctor by the name of Carlos Schenk. And somebody came into his clinic and said, last night I woke up and I was on the side of my bed with a rifle pointed, and he was a vet, and I was trying to shoot somebody. Previously, I used to be a running back, and I just was running into my dresser wall, and nobody had ever diagnosed this before. They just said, oh, you did that in your dream, whatever. But this guy started to follow a pattern of these patients. He created this giant cohort of these patients, and 85% of those patients went on to develop Parkinson's.
Really? I didn't realize there was an actual like. Then that's a really good reason. If people are doing things that maybe are like really harmful, if they're doing weird stuff, they should get looked at.
Oh, for sure.
Interesting. even the people who are making like, it's just the REM sleep ones, not people who are like making sandwiches at night.
Sandwiches at night, that's sleep eating. For those patients, you should tell, I want you to increase your total sleep time, and I want to make sure you don't have sleep apnea.
That makes sense, but there's a.
Those are non-rep.
Those are non-REM drugs. Yeah.
Thank you so much.
You are welcome.
Thank you.
Very wonderful.
You're